Welcome to class, everybody. I hope you all had a great weekend, and I hope you guys are all as excited about the holiday break as much as I am. Today, we're going to go over the 2023 American Diabetes Association Guideline Update for Type 2 Diabetes Management. Our goal for today is I'm going to introduce the new guideline to you for 2023 with regards to type 2 diabetes blood glucose lowering medication management. I just want to remind you guys that in our module for this week, you should have already gone over the textbook reading that was assigned to you. You should have already watched the YouTube video about diabetes management. You should have already reviewed the 2020 guidelines for diabetes management, which I'm sure all of you guys are well rehearsed in by now anyway. And then in addition to that, you should have briefly reviewed the 2023 guideline for today, which is what we're going to discuss. Our objective for today comes from our outcomes, which our level 1 outcome is for you guys to demonstrate the knowledge of disease state guidelines. You guys should have already created your study guide for your first-line treatment options for type 2 diabetes according to the new 2023 updated guideline. You should be able to compare the previous guideline with the new recommendations today. You should be able to demonstrate the appropriate selection of treatment options for your patients. We're also going to discuss the most valuable concepts of diabetes management, and by the end of today, you should be able to appropriately treat or discuss treatment options for your patients with regards to their symptomology and past medical history. Again, the resources were already posted for this week, your textbook, the YouTube video, and the guidelines from 2020 and the guidelines from 2023. So just a brief overview, you guys know diabetes. We've gone over it so much already. Type 1 diabetes is that autoimmune disease. There's no cure for it. The patient's pancreas is not secreting insulin, so they will be dependent on insulin for the rest of their life. With type 2 diabetes, the body is unable to produce effective insulin. There is no cure for type 2 diabetes either, but it can be put in remission through medication management and lifestyle changes. Again, the goals for diabetes management, this is not how to diagnose diabetes. These are the goals of treatment. So once you have your patient that you have successfully diagnosed with diabetes, we want to make sure that we keep their fasting blood glucose below 130, that their 2-hour postprandial is less than 180, and that their A1C is treated to 7%. Now let's review the 2020 guidelines. I'm just going to highlight a couple of things here because you guys should be well rehearsed in this already because this is what you have been prescribing for your patients thus far. Remember that all patients, when they're initiated on diabetes management medication, it's usually because they're started on metformin for the first 12 weeks of therapy. After those 12 weeks, if the metformin is not as effective as it needs to be or the patients can't tolerate the side effects, we're going to go ahead and either treat them based on their ASCVD risk factors or if they have chronic kidney disease. If they don't have any of those issues, we're going to be looking at, does the patient suffer from hypoglycemia? Do we need to promote weight loss? Or does the patient not have any insurance to be able to cover their medications? So there's a lot going on here with this 2020 recommendation. It's a lot better than the 2018 recommendation, but there's still kind of a lot going on. That's why I really like the 2023 guideline update. It's very straightforward. And it very much gives a detailed representation of what we need to be focusing on for diabetes treatment. So let's go ahead and discuss it. So this is the new picture graph representation of the 2023 diabetes guideline for medication management. So here you can see metformin is no longer the first line therapy. It's not you've been diagnosed with diabetes and here's your metformin. We are starting to see specifically that we need to give patients that are high risk for cardiovascular disease, heart failure, and chronic kidney disease, that we give them special medications because of the clinical data. And then everyone else is lumped into, do they need to focus on glycemic control or do we need to focus on weight management? So let's go ahead and delve into these categories a little bit more. So for the cardiovascular risk recommendations, here we can see patients that have ASCVD or cardiovascular disease, patients that have heart failure, or patients that have chronic kidney disease are going to be started off on that GLP-1 or SGLT2. You guys should be very well rehearsed in these medications. What's really important to remember about these medications now is that SGLT2 has been confirmed to have mortality and morbidity benefits in our patients with heart failure, specifically reduced ejection fraction heart failure, so our HFrEF patients. We don't necessarily know why it's renally protective, but we know that it is, and so that's why we've been starting to recommend it. However, so we do start to put these patients on SGLT2s most of the time unless they're contraindicated. So unless a patient really cannot tolerate a GLP-1 or an SGLT2, that's why we would prioritize one over the other. Also, for patients with chronic kidney disease, one of the reasons why we would prefer a GLP-1 is only if their renal function is so low. So if their renal function is less than 30 mils per minute, we would go ahead and put them on a GLP-1. So remember, our SGLT2s are our gliflozins. Per the CVOT trials, the cardiovascular outcomes trials, we saw significant reductions in the risk of death from cardiovascular diseases. Again, this is where we see our HFrEF patients really benefiting, regardless if they have diabetes or not. We saw a significant reduction in worsening heart failure and risk of death from cardiovascular causes. So we're going to start to see a lot of patients that don't have diabetes and just have heart failure being treated with these SGLT2s, specifically Farxiga, seeming to be the most in favor for these patients. It is contraindicated in patient with their EGFR less than 30 mils per minute, which is what I mentioned briefly before. So that's why we're going to transition into our GLP-1s for our chronic kidney disease patients that are really in that stage 3, stage 4 chronic kidney disease that are really in need of blood sugar management. So again, our GLP-1s are our glutides. Again, for our cardiovascular outcomes trials, we did see significant reduction in risk of death from cardiovascular causes. And this is where we're going to highlight dulaglutide or Trulicity as our primary stay of therapy in our chronic kidney disease patients with an EGFR less than 30. Now, this is the other half of that graph. We're going to talk about achieving and maintaining glycemic and weight management goals for our patients. So specifically for glycemic controls, we're going to see it says metformin or agents including combination therapy that provide adequate efficacy to achieve and maintain treatment goals. So this is the first time in this guideline where we're starting to see metformin or. So maybe our patients can be on metformin if their A1C is not atrocious, if they really have a fear of needles. Metformin is still a great drug. As you can see on the high portion, that's that orangey color, metformin is still listed there as being very effective for reducing A1C. However, what we're starting to see is that we have Ozempic, Mounjaro, Trulicity. Those medications are becoming the forefront of therapy. They are all injectable medications, and they're significantly reducing our patients' A1C values. When we also look at weight management, we're starting to see that doctors are really going to have to start promoting lifestyle changes. Yes, when you go to the doctor and you're a little overweight, I am also guilty of this. It is kind of uncomfortable for your doctor to constantly remind you, hey, you're 10 pounds overweight, you're 20 pounds overweight, you need to start losing weight. What this guideline is really helping healthcare professionals do is transition from the blame game and transition from the you're overweight. We already know that. Your patients already know that. But transitioning to incorporating an actual intervention. So instead of telling your patients they're overweight, telling your patients, let's get you started on a nutritionist. You need to start walking 10,000 miles a day. When you're doing your blood sugar guides and you bring those values into me, I want you to start bringing in your walking logs into me as well. So actually considering alternatives to just the you're overweight. Also, the recommendation on here is also metabolic surgery. So this is where we're going to start talking to our patients about surgical interventions as well, which is the first time the guideline has ever recommended something like that, which is huge. So for weight management, we're starting to see new medications come up with new mechanisms of action that we're going to talk about. But just know at the forefront for both of these, we have Ozempic and Mounjaro. Also, that Trulicity is on there, but for weight management, it has been demoted from a very high to just a high, which is still great. So let's talk about that. Mounjaro is a brand new type 2 diabetes medication. It was approved by the FDA in 2022 for the treatment of type 2 diabetes. It proved itself superior to Ozempic in head-to-head trials, which is huge. And currently it is in clinical trials for obesity. Those trials are set to drop in March. So it's really exciting to see that come about. Let's do a comparison of Mounjaro, Ozempic, Victoza, and Trulicity. This is going to be very brief because of the resources that have already been proposed in class. But the reason why I'm putting this here again is a reminder that these medications are very effective for weight loss, but there is no FDA recommendation for weight loss at this time for these brand name medications. However, with that being said, we need to be cognizant is that when these patients are on these medication, all the clinical trials across the board for these patients show that these patients are losing significant amounts of weight just by incorporating these medications into their daily routine. However, the trials are also showing that these patients are gaining all of that weight back as soon as they discontinue the medication. So as a practitioner, as a provider, as a pharmacist, you guys, we all need to be on the same page of incorporating those healthy behavior lifestyles with our patients so we don't see them having these yo-yo effects, because at the end of the day, that's going to cause more harm to their metabolic syndrome and cause them to have worse prognoses lifelong. So we want them to healthily, or in a healthy way, I should say, reduce their weight while taking these medications. So in the Mounjaro trials, we are showing that patients in comparison, or patients at the highest for Mounjaro and patients at the highest medication for Ozempic, they're losing about a 10-pound weight difference in loss, which is huge. And we're also showing that their A1C is coming down by about 2%, which is the highest for all of those injectable medications for these two drug classes, which is incredible. Ozempic also showing very similar efficacy. For weight loss, it just doesn't perform as well. Still performs very well. It's just not as adequate. For Victoza, we are also seeing similar results. And same with Trulicity. What I do want to bring to light as well, as in addition to not having your patients yo-yo from huge weight loss to huge weight gain on these medications, is even though these medications are in the guidelines right now, manufacturers Novo Nordisk and Eli Lilly, which are the two biggest manufacturers for all of these medications, have projected market shortages until the end of 2023. So it's really going to be hard when these recommendations drop, these guidelines drop in 2023, and we're all prescribing these medications for our patients, but now our patients don't have access to the medications because they're just not being produced enough. So really take these recommendations take them in knowing that your patients may have difficulty getting the medication. So yes, this is our first line therapy, but we also need to have backup plans for when our patients don't have access to these medications. So here's our case study. This is an application question. I really want you guys to spend some time in groups, and then we'll come back in a group setting to talk about your answers. So WS is a 35-year-old woman who was diagnosed with type 2 diabetes. At 30, she's 5'5", 200 pounds with a BMI of 33 and an A1C of 9.1%. She's no relevant past medical history, and her lab values are within normal limits. She presents for diabetes follow-up. Her problem is that she's been on metformin and Farxiga for 2 years. Her A1C has come down, but only slightly. She's feeling demotivated, and she has a pill aversion. Based on the new guidelines, go ahead and follow through these questions, and we'll go ahead and regroup in a few minutes to talk about this. All right, guys, we had a great discussion. I'm really impressed with how you guys thought through the answer for this. I do just want to recap today. We did talk about the new 2023 diabetes guidelines. We talked about the differences in therapy and what we need to be vigilant about in prescribing these for our patients. We also went through an application of this case study. This is a real live person that you're going to see in your clinic. So hopefully after today's lesson, you feel comfortable with the new guidelines, you feel comfortable with the new medication that's on the market, and you feel comfortable talking about that with your patients. I hope you guys have a great holiday, and we'll see you next week.